what is incretin axis and how these DPP4 inhibitors act. That is the first thing. The second thing is about the cardiovascular outcome trials, which you all need to know. Why these cardiovascular outcome trials came and what did we learn from all these cardiovascular outcome trials and how we can extrapolate all these cardiovascular outcome trial in the perspective of DPP4 inhibitors. Again, when we talk about SGLT2 inhibitors, we will discuss in details. But as far as the DPP4 inhibitors are concerned, we have lots of knowledge which we have gained based on this cardiovascular outcome trial. So what lessons have we learned over there? And the practical points with respect to DPP4 inhibitors. So this is a very nice experiment which they did as early as in 1960s, where they tried to do very small subgroup of people were enrolled into this study. And where they tried to do is, they tried to give oral glucose on day 1 of the patient. So on day 1, they were giving oral glucose to the patient. And on the day 2, the same patients were called back and they were given intravenous glucose to match the same profile of the sugars that was happening with the oral glucose. So the insulin glucose was titrated in such a way when they were given an intravenous glucose that was matching with the plasma glucose. So the peak of plasma glucose which was happening and the changes that was happening with the fasting blood sugar was matched in both these arms. This is the experiment model that they were doing. So in this model, what they have added another thing is there any difference between the amount of insulin which was secreted when it is given by the oral route or by the intravenous route? So when they saw the amount of insulin which was released with oral route was much higher than when the same glucose was given by an intravenous route. So that is what they tried to see, like the amount of insulin which was getting released with the oral route was much higher than when it was given over the intravenous route, which we call it as the incretin axis. So there are some enzymes or hormones or some which they didn't know at that point of time, which was getting released in response to the oral route, which was not available for the intravenous route. Later, we tried to find it out as the incretin molecules or the GLP-1 or the GIP-1, which were responsible for this effect. So this phenomenon of increase in the plasma insulin when the glucose was given by oral route than by the intravenous route, and this phenomenon is called as the incretin phenomenon. So this experiment happened in 1960s. So again in 1970s the experiment was repeated. Again this had a very small experiment where, like, in the healthy individuals there are about 8 patients and in the type 2 diabetic were 14 individuals. They tried to do the same experiment. So as you see, in the healthy individuals the amount of insulin which was secreted to oral response was much higher. Rather, this peak in the insulin secretion was getting dampened in type 2 diabetic. So they were able to postulate that incretin axis or this dampening of the insulin effect also can be a cause for the type 2 diabetic people. So this is what hypothesized at that point of time. So it didn't take off by any means after that, but the hypothesis says that the dampening of this insulin secretion which happens in response to oral glucose is diminished in, or the dampening effect happens, or the insulin doesn't peak like it happens in the people who are taking oral route in type 2 diabetic people. And this dampening of this incretin could be an pathogenesis or could be causing type 2 diabetes in this people. So this was the second hypothesis that was learned. So the first one was, we learned what is incretin and how it comes, and this effect is dampened in type 2 diabetic people. So with this, whatever we have learned came to a still effect, because like there were no therapeutic molecules available. We understood that this phenomenon is happening and this dampening is happening in type 2 diabetic. But we didn't have any molecules to address this phenomenon. So it was all in the primitive state and nothing happened after that. So this effect, then later we understood, so this effect, this incretin phenomenon is not only happening because of endocrine transmission, there could be a neurotransmission, there could be a substrate stimulation also which can cause this incretin phenomenon. So it is not like The reason being, this phenomenon was happening within just 15 to 20 minutes of someone taking the food. So if it exactly happens only because of the carbohydrate or proteins which are consumed and reaches the stomach, it will take more amount of time for this phenomenon to happen, because the carbohydrate has to be absorbed and it has to reach the bloodstream. It was as the effect was appreciated even within 15 minutes. So they concluded it is not just the local phenomenon. It could be the endocrine transmission, or it could be the neurotransmission, or as we see, like it could be the substrate stimulation which goes to the gut and stimulate the effect. So it is not only through this phenomenon, it could be the other ways also which might be causing this effect. So this we learned subsequently. So with all this understanding of incretin phenomenon, this effect getting dampened in type 2 diabetic, and there could be the other alternative ways where it can get stimulated. So we learned that there are two hormones which are responsible for this. The first one being the GIP, glucose-dependent insulinotropic polypeptide. So in the fasting state, the circulated GLP-1 level is very low and reaches its peak in 15 to 30 minutes after food ingestion, especially food which contains carbohydrate and fat. So GIP was the first one which was discovered and to show this incretin effect. So this is the first incretin hormone, rather we can say, which peaks in 15 to 30 minutes after food ingestion, and it gets stimulated with carbohydrate and fat.